Greetings everybody, and welcome to Silverio Lining. Today we'll be discussing priapism, one of the hardest topics in emergency medicine. Let's begin with some basic penile anatomy and terminology. When using the words ventral and dorsal, we're dealing with the penis in its erect state. So the corpus spongiosum is the single unpaired erectile tissue on the ventral aspect of the penis. It terminates in the glands, while the corpus cavernosa is the paired erectile tissues that are on the dorsal aspect of the penis. These are the major players in priapism. There are two primary causes for priapism. The first primary cause is low-flow priapism, which is also known as venous occlusion priapism. This kind of priapism causes penile ischemia and compartment syndrome because it prevents venous outflow of blood, which in turn prevents arterial perfusion. There's also high-flow priapism, which is a tumescence of the penis that's caused by arterial hyperperfusion, a failure to modulate the arteriolar flow. Approximately 95% of priapism is low-flow priapism, and 5% of priapism is high-flow priapism. Another important note to mention about priapism is that the technical definition of priapism is 4 hours of penile tumescence. So if you have somebody who's had an erection for 2 hours, we can understand how that might be frustrating, but it doesn't quite qualify. Just go wait in the waiting room for another 2 hours. There are a few different common causes of low-flow priapism. Of course, it can happen to unsuspecting healthy people, but that's a little bit less frequent. One of the most pernicious causes of low-flow priapism is sickle cell disease. Priapism is essentially an ischemic emergency of the penis, so it's easy to imagine that sicklers who have ischemic emergencies of joints and of organs could also have ischemic emergencies of the penis. The other common cause of priapism is drug-mediated ischemic priapism. This can be from prescription drugs, for example, sildenafil for people who have pulmonary hypertension or chronic erectile dysfunction. This can also be caused by recreational drugs such as cocaine. High-flow priapism is a problem of regulating the arteriolar flow of the penis. So anything that damages the arteriolar regulatory system can result in high-flow priapism. For example, a cervical spine injury that causes damage to the sympathetic and parasympathetic pathways can cause priapism. A pelvic fracture causing an arteriovenous fistula can also result in high-flow priapism. So what do you do when you have these patients in the emergency department? Please start with anesthesia. You grab a 30-gauge needle and a 20cc syringe. The needle should be long as well because you have to go all the way from the skin to the pubic symphysis. You want to be able to hit with the tip of your needle the inferior border of the pubic symphysis at the 12 o'clock position of the penis. You insert your needle all the way until you hit bone, and then you pull back a teeny weeny bit and inject about 10 to 15 cc's of lidocaine or bupivacaine. As you're pulling out, you also want to get a nice wheel around the dorsal aspect of the penis so that you can do an appropriate, almost ring block of the most proximal aspect of the penis. Make sure not to use epinephrine with this block. After you've adequately anesthetized the patient, your next step is to perform a simple aspiration, which can resolve 24 to 36% of ischemic priapism. Grab a 19-gauge needle and a 5cc syringe and insert at approximately the 10 or the 2 position of the penis. You're essentially shooting for the corpus cavernosa. Once you've injected into what you feel is the corpus cavernosa of the penis, you can attempt to withdraw fluid. You'd like to withdraw about 5 cc's of blood, if you can, from the corpus cavernosa. Again, this resolves 24 to 36% of priapisms. If aspiration has been unsuccessful, you can totally move to irrigation. You use the same needle and syringe setup, except this time you inject 1 milliliter of solution prior to attempting to withdraw. The recommended solution for injection is approximately 100 to 500 micrograms of phenylephrine per milliliter of injected fluid. Formal recommendations state that this should be done every 3 to 5 minutes for 1 hour prior to progressing to surgical repair, by which time hopefully urology is on their way. As a final horrifying last-ditch effort, it is recommended to create a surgical fistula between the corpus cavernosa and the glands of the penis. You grab an 11 blade and you make incisions again at the 10 and 2 position, this time of the glands. By doing this, you are creating a fistula between the corpus cavernosa and the glands, and should then be able to express the clotted blood out of those large glands incisions. High-flow priapism, on the other hand, is not quite an emergency and therefore can be treated more conservatively, thank God. Normal mechanisms of decreasing swelling are king in this scenario. Your primary advice to your patient is to use rest, ice, and elevation of the tumescent penis. If that is not successful, then you can apply some focal compression to the penile artery in hope of decreasing the arterial perfusion by direct pressure. These patients will eventually need angiography and/or embolization to prevent permanent penile tumescence if it's bothering them, but this can be something that can be done by the professionals. Well, everybody, thank you for joining in this exploration. This has been another enlightening session. I hope you have a lovely day.